Hello and welcome to this 1-hour webinar on spine anatomy, pathophysiology, and CPT coding challenges brought to you by Healthcare Resource Group. I'd like to start by offering up the references, some of which I used during this webinar presentation. I certainly encourage you to avail yourself of or acquire these resources to have on hand as well, and you may actually want to go ahead and open up your CPT manual now so you can follow along. CEU Credit for this webinar presentation is available through both AHIMA and AAPC and is a 1 hour for each. The CEU Credit is earned through taking a post-test at the end of the webinar here. Information will be provided to you. The course is valid for CEU for up to February 21st, 2019, but you're welcome to enjoy it after that, although be advised, CPT does change. The learning objectives required to be approved for CEU here, and which the test will somewhat adhere to, you'll see before you here. These are also my objectives and goals for you somewhat as well, but beyond these are somewhat of a formality. So mainly the spine anatomical landmarks and the anatomy of the spine altogether is pretty complicated, worth looking at lots of slides and diagrams so you can best understand this. So if you can understand the anatomy of the spine in your mind's eye, it is my belief that it will really help you to code procedures as you can see them sort of happening in your mind's eye as you read them on the page. I would like to make great emphasis on the distinction between anterior and posterior spinal fusions and make sure you really take that message home, particularly if you're just beginning coding spines. Would like to discuss some of the surgical treatments of common spine disorders, namely decompressions, fusions, and a couple of other odds and ends. That accounts for probably 90% of what you're going to find in spine surgery these days. But being careful to note that spinal fusions usually require a combination of codes to tell the whole story, but it's easy to overdo that too, so there's some bundling to watch out for. Now there is also quite a variation in the way surgeons describe their cases from surgeon to surgeon, and we as coders need to be able to translate those all back to the common concept of the CPT code. My name is Ed O'Byrne, and I'd love to be with you there giving this presentation, but in lieu of that, I'll just kind of hang out up here in the corner here. I was an emergency medicine physician assistant for the first half of my career. I've been happily in coding, consulting, and education for the last 10 years, and I'm currently the Director of Revenue Integrity for Healthcare Resource Group. Now the agenda for the presentation, so you know what you're getting into today, we'll first look very carefully in great detail at the spine anatomy. This is something that I confess I didn't receive very much of in PA school. I had to avail myself later when it became that much more important when coding these complicated procedures. We'll go into some spine pathophysiology. You'll see some disorders that may look familiar to you there. Spinal stenosis is a common one, disc herniation, or both. And then we'll look into the procedure coding challenges. Now, this isn't meant to be an exhaustive start to finish instruction on how to code spine surgeries, but just to kind of pick on some of the low-hanging fruit for you, that is common procedures, tricky to code procedures in this case. Now, I like to use lots of illustrations and pictures. There's only a couple of actual surgeries in this, so there's a little bit of blood, but all in good taste, but lots of illustrations and drawings that hopefully you will find those useful. So we'll start with the most fundamental part of the spinal anatomy, and that's the vertebral column regions, the cervical, thoracic, and lumbar. And for the purposes of coding and surgery, consider these numbers fixed, 7, 12, and 5. And the sacrum is really one unified bone, but it's fused from 4 or 5 sacral vertebrae when we're infants. So effectively that becomes one bone. So this is something that most of us learn, and make sure that you've got a strong concept of the regions of the spine. Now, interesting side note, if you get to know me a little bit, you know I'm kind of a science nerd, and I like to take a little digression here to tell you about some variations in the animal kingdom from the number of cervical vertebrae in particular. Thoracic and lumbar vertebrae vary some too, but there's some kind of interesting notes for the some variations. The manatees have 6 cervical vertebrae, not 7. Two-toed sloths can have 5 to 7. It's not only interesting that it varies from 7, but it varies in the actual animals. It's very strange stuff. And that its cousin, the three-toed sloth, has 8 or 9. Who knows why? The vertebral segments are coded by so-called Hox genes, which differentiate segmented body parts, anything from earthworms up to humans. So if there's a segmented body part in which each of those segments has to differentiate itself from its neighbor, Hox genes are responsible. So abnormalities in this such as I'm about to discuss, may come from Hox genes. The variations in humans, though, are the so-called cervical ribs, which occur in about 0.6% of people, and those are two little ribs that can grow off of the 7th cervical vertebra, just above the 1st thoracic. It does not make that cervical vertebra a thoracic vertebra. So if you were ever to see a procedure performed on a cervical rib-bearing C7 vertebra, it's still treated as a cervical rib. Sometimes the thoracic vertebrae are so-called rib-bearing, but that is in a kind of a soft sense. So we're still dealing with 7 cervical vertebrae, even though one of them may have a pair of ribs on it, very small ribs, not usually causing any problems incidentally, usually just found on x-rays or surgery. The second, sacralization of a lumbar vertebra, where in L5, the last lumbar vertebra may be fused completely or partly to the sacrum. So it acts a bit like a part of the sacrum, still lumbar vertebra. And then the reverse of that is lumbarization of the sacral vertebra, where the S1 segment never quite fused to the S2 and down below. So it may actually have a little articulation in the sacrum, still sacrum, okay? Now the vertebral columns, this is a less intuitive concept which most of us didn't learn in grade school. It's not hard to get your head around, but it does require going over the anatomy in somewhat detail. Start with the easier of the two, the anterior column. So that's the part that faces forward, so into the front of your neck, the front of your thorax, and the inside of your abdomen if you go in anteriorly. And essentially the anterior column is comprised of the vertebral body. And speaking of bony landmarks, the vertebral body, that's pretty much it. The anterior column is subject to anterior fusions. So you see interbody or intervertebral body procedures, you know you're dealing with the anterior column. Then the more tricky part is the posterior column. And in this bone here, this patient will be facing up or supine. So there's the front of their body, the rear of their body. So the posterior column are all of these elements you see here that combine to form what's called the vertebral arch. And a couple of other names for that are the spinal canal. Occasionally you see vertebral foramen, and that is mostly to differentiate it from the neural foramen. The neural foramens are foramina are where the nerve roots exit from the spinal cord, whereas the vertebral foramen technically is the spinal canal where the spinal cord passes through. And then embryologists and biologists sometimes will refer to it as the neural arch, and that's a certain way of differentiating vertebrates from other animals too, but once in a while you'll see that. So the posterior column is comprised of the pedicles, lamina, transverse, and spinous processes, and so we'll spend a bit of time looking at each of these in a moment. Let's starting with the anterior column. So we'll first start this series of diagrams showing each of these bony landmarks. So the vertebral body, this patient is prone, so here's the posterior column, the vertebral arch, and the anterior column, that's a vertebral body. Viewed from the side, it's somewhat square-shaped, sometimes a little convex or concave, but for the most part that is the load-bearing hard part of the spine that bears our weight against gravity, and it's like a series of cans stacked upon one another with the discs in between. Under the posterior column, so we'll see this again, this patient is, we're looking down axially straight down the spine from the top. The pedicles. The pedicles are like feet, and it indeed comes from the Latin for peds, like podiatrist or pediatrics, which actually is, kids are named after little feet because they come up to our feet. Anyway, pedicles are these two columns that hold up the rest of the posterior column of the spine. You can see the rest of the posterior column of the spine being held out by these, I call them columns, but more like pedestals from the vertebral body. You'll see between the pedicles is the neural foramen. We'll make a tremendous amount of emphasis on this during this talk, as that's where the exiting nerve roots come off of the spinal cord between the pedicles. So notice that the pedicles are part of the boundary of the neural foramen there. Moving on to the transverse process, the processes that poke out to the sides. These are not palpable. You can't feel these in a normal person. And they're ligamentous and tendinous attachments. Hardly anything ever goes wrong with these. Occasionally fracture can occur, which is painful but otherwise benign. Transverse processes are a common site to apply bone graft for posterior column fusion, but otherwise that's about it. And they do not bound to the neural foramen. What you see here is the transverse process sticking out at us. It's not actually part of the window that's the neural foramen. On to the lamina, which you'll see a tremendous amount of mention of, as it's the site of a laminectomy and laminotomy. The lamina are like the roof of the vertebral arch or the spinal canal, and they're thin, bony coverings. It's the access point typically for decompression maneuvers, with the exception of going through the foramen itself. But most decompressive maneuvers are through the lamina, and they do also bound the neural foramen here. You can see it forms that posterior part at about the 9 o'clock to 11 o'clock position right there. The lamina are also subject to posterior column fusions. Oftentimes whatever's left of the lamina after the laminectomy then is fused in place. And then finally, the spinous process. This is the part that you can feel when you poke in your back that sticks immediately posteriorly. It also is not involved in many forms of pathology, can also occasionally fracture, causes pain, but no problem. But what it is, though, is a common bone graft donor site, wherein the spinous process is munched off and crushed up and then used as a graft elsewhere in that general vicinity to perform a fusion. And then finally we have the facet joints, and these also form part of the boundary of the neural foramen here from about 9 o'clock down to about 7 o'clock here before you get down to the pedicle on this end and the facet joint itself here. The facet joints provide some of the articulation of the spine, and they, since there are two of them, in concert with the intervertebral disc here, form sort of a tripod arrangement of joints. So it's nice and stable when stacked up. Intends to, in a neutral position while standing, provide a nice pathway of the force of gravity down through the spine. But most of the weight itself is actually borne through the vertebral bodies and the discs themselves. Now, the facet joints can, like any joint, develop arthritis, and that can encroach in the neural foramen. So the facet joints are subject to excision and or fusion too, to alleviate that any pathology that develops there around the neural foramen itself due to the facet joints. The facet joints have another name there, notoriously difficult to pronounce. The facet joints are plane or gliding joints, so they're not like a ball in a socket like the hip or the shoulder. They simply slip by each other like this. So in flexion and extension of the spine, the facet joints just slide back and forth. They're boundary of the neural foramen, as I mentioned. Next, moving away from the bony landmarks of the spine, let's look at the ligaments. And there are many of them and somewhat complicated. I'd really like to just look at these two, the ones that you'll commonly see in operative reports. The first is the ligamentum flavum. You see right here, ligamentum flavum attaches lamina to lamina to lamina all the way up and down both sides of the spine. So you can also see them right here and here. The ligamentum flavum forms the posterior boundary of the spinal canal, and therefore when the ligamentum flavum becomes thickened or hypertrophied, it can encroach into the spinal canal, and it can press on the spinal cord, which passes here, and or the exiting nerve root, which goes through the neural foramen there. The next ligament I'd like to draw your attention to is the posterior longitudinal ligament. Longitudinal as it runs the length of the spine, just posterior to the vertebral bodies. It occasionally can also hypertrophy and push on the spinal cord from the front, pushing back from the front, but the main mention of the PLL you'll see is in anterior decompressions and fusions in the neck almost exclusively, but these days. But you'll see that they enter through the disc, empty out the disc, and then cut away the PLL in order to access the spinal canal for the decompression itself. So there's a couple of ligaments of the spine. Now the anterior column, as it relates to the associated soft tissue and neurologic structures, the intervertebral discs, we'll come back to more of that later, the spinal cord inside the dura, which is represented by the purple part here, and then the nerve roots, the cervical, thoracic, lumbar, and sacral nerve roots, which come off in pairs. So the bone itself is, again, it's cylindrical bone. It has cartilaginous end plates just like any other bone, humerus, femur, or otherwise. It's just that this cartilage is sort of transformed into more of a squishy synovial fluid instead of liquid, and the ligament forms the annulus fibrosus, which is the casing around the disc space. So think of the disc almost as the cartilaginous end plates of any other joint in your body. Now this interspace is a joint itself, and that's more for like PCS coding purposes, but the disc itself is a highly modified joint. Now the discs themselves, drilling down on that a little bit, you'll see the annulus fibrosus. That's effectively all of the collective ligaments around the disc substance and attaching one vertebral body to the next, just like the ligaments in your shoulder or joint or hip and so forth. It forms a ring. Annulus is ring. It can be spelled with one or two ends. And then the synovial fluid inside a normal joint is liquid, like in the knee, and that's the lubrication, whereas in the intervertebral disc, it forms a nucleus pulposus. It's much more thickened. It's not slippery. It's squishy like a gelatin. For shock absorbing purposes, one can only assume. And then the spinal cord and nerve roots. Now, this is usually the focus of most spine surgeries after all. The problems with the spinal cord and the roots themselves, actually the substance of the nerve tissue itself is kind of on the low side. But being surrounded by all these bony structures, they're exquisitely sensitive to any problems forming with those, such as arthritis, compression, etc. Here's the spinal column, the spinal canal again with the spinal cord in it, and the neural foramen with the exiting nerve roots there. So now you can see it all kind of come together in the arrangement of the vertebra and the spinal cord and the nerve roots. Okay, so what are the symptoms of back problems? Well, looking at nerve root compression symptoms, because the nerve roots are both sensory and motor, a patient can have pain and or numbness and or weakness and or other muscular symptoms such as incontinence, which is effectively a motor weakness. Now, the nerve root as it exits the spinal cord occurs in two sections, the dorsal root and the ventral root. And the dorsal root is sensory nerves. So if you can imagine, these blue nerve fibers come from, let's just say, your fingertips and your tip toes for sensation, for pain, for temperature, and so forth. They travel all the way up to this dorsal nerve root ganglion right here, which is a cluster of the bodies of the nerves themselves and synapses to the dendrites of the remaining spinal cord tracts that go up into the brain. So it's like a little nerve transmission zone right there. So any impingement on the dorsal nerve root tends to cause pain or numbness or some sort of sensory symptoms, whereas the ventral root towards the belly, towards the front of the body, those are motor nerves, and those extend from nerve bodies either in the brain or the spinal cord itself, and they just come and exit right off into the ventral root. But what happens is the nerves mix as they go to the dorsal and ventral ramus that have mixed sensory and motor functions too. So depending on where the compression occurs, it can cause exclusively sensory or exclusively motor symptoms or a mixture of both. And you can see both of these, the nerve roots, dorsal and ventral, occur inside the dural sac. So the dural sac is the green part that you see right here. And that's sort of treated as just one big lump. Now the neural foramen kind of starts right here and as it exits, and then the outside is about here. So all these connections sort of occur inside the neural foramen. And here's another cutaway of that. So you can see the dorsal and ventral nerve roots combining together and then branching back off into rami, and then as it exits the neural foramen. So here's where it would enter the neural foramen on its way out, and there's where it exits. So what can go wrong with the back, and notably the central nervous system and peripheral nervous system that comprise the spinal cord and the nerve roots? Number one, problem one, spinal canal stenosis, something that is pinching on that otherwise free space of the spinal cord to move around as we articulate our backs and move around in our day-to-day life. Ligamentum flavum hypertrophy from the rear can cause stenosis. Facet hypertrophy or arthritis, spondylosis is a fancy way of saying facet joint arthritis. Disc disease, the disc would be here, can herniate, bulge, or otherwise press from the front towards the back against the spinal cord. And then osteophytes can form in any number of areas from the lip of the disc to the facet, etc., and come in and around the spinal cord. So that's spinal stenosis. Problem number two, foraminal stenosis. So this is where the neural foramen is enclosed, and as I remarked, several structures form the boundary of the neural foramen. So facet joint arthritis can encroach here. Disc herniation can encroach there, usually as slightly lateral disc herniation. Osteophytes from the facet joint, essentially all the same problems that can cause spinal stenosis can cause foraminal stenosis. Problem number three can occur is compression of the spinal cord without or of the exiting nerve roots, usually by vertical loss of spacing of the the disc space. So when viewed from the side, this will become more apparent. But imagine this disc has become shortened and compressed together. So is compressed the spinal cord and the nerve roots in that vicinity. The nucleus pulposus shrinks over time inevitably with age due to dehydration, but it can also protrude out in one direction or another, whether it protrudes actually against the spinal cord itself and causes problems, or it can protrude anterior or laterally, which in and of itself is symptomless, except it causes a decrease in height of the disc, and that's what causes the compression. So let's focus on one version of that, the disc herniation, some types. It can be chronic or traumatic, and most commonly it is presumed it's kind of a combination of both of those. It's sort of chronically trying to herniate, and then there's one inciting event that causes it to finally herniate out. It's distinct from a bulge. A bulging disc is still within the annulus fibrosus, and yes, it can push on things, but it's rarely nearly as bad as the true disc herniation, wherein the nucleus pulposus actually comes through the annulus and is floating freely in whichever direction it chose to herniate. And this can cause pressure on the spinal cord, the nerve roots, or both. And that's the mechanism by which it causes pain, is it pushes against the metabolically very sensitive nerve tissue, which needs its glucose, it needs its oxygen and blood supply, and any compression of that causes to starve some of that nutrition and oxygenation, as well as causing a direct irritating function just by being there physically. So disc herniation is seen from the side. A posterior lateral herniation here is viewed axially here from atop the patient. The disc is bulging out through the annulus against the nerve root, and here you can see it from the lateral side. And this area of the nerve root has become partly starved of its nutrition, as well as directly irritated by having just a big chunk of disc right against it. Here's what you might see on an MRI from the side. This patient's from the left side, posterior to our right, anterior to our left. You can see the nice spinal cord. It's nice bright white on this MRI weighting, and it gets very thin right here, and then it becomes thick again because of this disc herniation protruding posteriorly against it and effacing or flattening out the spinal cord. You can also see that the disc height of these what's this, 4, 5, 3, 4, nice and high, nice and high, nice and high, pretty narrow. So this vertebra is dropped down in relation to the sacral one vertebra. Now, a quick aside about the anatomy of the lower spinal cord. Now, we constantly refer to it as the spinal cord, even at the lower lumbar regions, when in fact it's actually breaks off into what's called the Cauda Equina, which means horse's tail in Latin, at the level of L1, L2 in adults. So the conus medullaris is the part that terminates the thick, what we think of as a cord, spinal cord here. It ends and then terminates in all these individual little fibers, which are like a horse's tail. Nonetheless, these are all still enclosed and encased in the dura, so it acts like one thick cord too. So when you see even a decompression at L4 or 5, it's kind of one unitary bundle of nerve that can be moved out of the way, that can become compressed and therefore need decompression and so forth. But the Cauda Equina is actually what's going on inside the dura. How about a cervical disc herniation? Let's see it on this particular MRI. False color. You can follow down the spinal cord and see right there where it's pinched. This is where the substance of the nucleus pulposus has protruded out from the cervical 1, 2, 3, 4, 5, 6 interspace and pressing directly against the spinal cord. And then on to the fourth condition or problem that I mentioned that does not truly directly affect the central nervous system or the peripheral nervous system per se, which is why I kind of set it off on its own, and that's degeneration. And the principal form of degeneration in the spine is spondylosis. That's simply arthritis of the facet joints. There are a couple of other rarer versions of this, but arthritis of the facet joints and of the disc space as well. Spondylosis. So it's effectively just arthritis of those particular joints. And like all arthritis, it can cause pain just by itself, even without anything pressing on nerve roots or spinal cord, like osteophytes and so forth. The joint can just hurt. The direct symptom of that is pain at that joint. And then again, the secondary indirect effect may be compression or can be both. Now, spondylolisthesis is kind of an interesting condition wherein the L5 vertebra slips forward in relation to the sacral 1 vertebrae here. So I've drawn a line here in front of L4 and L5, and you can see they more or less line up. L3 is right there as well. Nice parallel, and then all of a sudden it just drops off like an overhang of a cliff back to here, and here's the sacrum. So this L5 vertebra has slid forward about, I'd say, 40% in relation to the sacrum. So because, as you know, the sacrum and L5 vertebra contribute to the boundaries of that L5-S1 neural foramen, ouch, it's become totally distorted now, and the nerve roots exiting that are now guaranteed to be pinched and painful. Interesting thing about spondylolisthesis is that the most common form of it occurs from an insufficiency fracture that occurs in childhood. Just some benign playing usually goes unnoticed, but it causes a weak spot in the bone that gradually slips later in life and then causes symptoms there. There are other subtypes of spondylolisthesis as well, but it's kind of interesting to think about. Okay, I promise I'm just about to dive into the procedure parts of this and then the coding after that, but I want to make one more quick mention of the conditions we're dealing with. So the spinal canal stenosis, conditions affecting it, and just kind of visualize the spinal canal and the many ways that other structures can encroach on that spinal canal. And then foraminal stenosis, to be cognizant of the neural foramen anatomy, the bounding structures, and which of those structures can encroach in the neural foramen. Okay, so let's look at spinal canal decompression. So we're decompressing the spinal cord and the nerve roots, and in the spinal canal model, we're looking at the nerve root that's in the spinal canal itself. We'll also look at the foraminal decompression as well. Let's focus on the spinal canal decompression. So we're dealing with spinal cord and a bit of the nerve root. And the two main modalities of that kind of decompression are laminectomy and laminotomy. Discectomy also factors into this too. It's sometimes done through one of those approaches, but as you'll see in the CPT, it's kind of considered part of that, the laminectomy and laminotomy. So the laminectomy in the textbook definition of it is a complete or substantial removal of one or both of the lamina. Now, this is the one area you'll see the most variation between surgeons and between patients is about how much of the lamina they remove. And surgeons approach this as they find the part of the lamina that's causing compression and they then take that off. And they don't concern themselves with where the line is between the two quite as often as we coders are required to do, because we only have two families of codes and we have to choose between the two. That laminectomy is done for access for a decompression, or sometimes when the arch itself is the problem, where the lamina is part of the bony trap for the spinal cord, so to speak. Now that's a laminectomy. Laminotomy is really, in its truest sense, is only for access. If a complete laminectomy is done, the spinous process is removed. This is your seal of quality that you're dealing with the laminectomy, because if the spinous process is taken off with the lamina, you know it could really only be a laminectomy. Laminectomy is coded per vertebral segment. Now we think about that traditionally as just one vertebra, like L3 or L4 or cervical vertebral segment 7, for example. But as I said, in reality, spinal surgeons typically treat the segment as the segment of compression, and it doesn't always line up exactly with one vertebra. So keep that in the back of your head. Now CPT coding for spinal cord and nerve root decompression effectively treated the same way in CPT. So those are your lamina in pink, so you can have those at the forefront of your mind as we proceed. So a lumbar laminectomy may be done to approach a ruptured disc, or to remove the bony constraint of the spinal canal where the lamina forms it. And in this case, this is a true textbook. This is the picture like you'd see in the CPT manual that shows a complete removal of the lamina from one vertebral segment here. In this case, it left the spinous process in place, attached by the opposite lamina, and just removed this one-sided lamina. But this is kind of a cartoon sense of how this is done, and oh, how I wish they were all quite so clear-cut in operative reports that would allow us to choose our codes, but they commonly are not. Okay, let's see how laminectomies look in CPT. We've got two big families of codes, or main families of codes for laminectomy and CPT. The so-called plain laminectomy, done without a facetectomy or foraminotomy, and the deluxe, which includes both of those elements. Now, laminectomy is done per segment and must include each of the elements. So removal of lamina, decompression of the spinal canal, and or neural foramen, a facetectomy, and a foraminotomy too. So 63001, 3, and 5 are the cervical, thoracic, and lumbar regions, 1 or 2 levels. That's an important note. 63015 is 3 or more levels done. This is pretty uncommon. The more common by far is what I call the deluxe, because it entails removal of the lamina for the spinal canal decompression plus a facetectomy, usually for foraminal decompression, and a foraminotomy itself, which is a carving out of the neural foramen, so the nerve root or roots, unilateral or bilateral, is acceptable in the code, to decompress that. So that's the full meal deal. So each level or segment requires the removal of lamina, facetectomy, and foraminotomy. So have a look at this example, which might look a little tricky on the surface. We have an L2, 3, 4, and 5 laminectomy and foraminotomy. So it's already starting to look like a 3-segment laminectomy. And we've got this nicely documented with foraminotomies and facetectomies. So far, we're thumbs up on meeting the deluxe codes. On the right, which is okay because it can be unilateral or bilateral, but L3-4, that's 1 foramen, and L4-5, that's 2 foramina. So that's only 2 levels. This is a good example of a surgeon removing just one long segment of compression and then doing a foraminotomy and facetectomy and a foraminotomy and a facetectomy. So that's just 2 codes. That's 63047, 63048. So to expand on that a little bit more, the plain laminectomy is, again, without any decompression of the neural foramen. So an example you might see, laminectomy and exploration or decompression of the spinal cord and or cauda equina. So that's just central compression. And here I've expanded the codes a little bit so you can see the descriptors, but I'm not going to make you read codes all day long. You can flip your book open and have a look at that. And the deluxe, the descriptor there, laminectomy, facetectomy, and foraminotomy, unilateral or bilateral, decompression of the spinal cord and or the nerve roots. So it can be for either, but commonly for both. And there are your descriptors for each of the 3 regions and the additional level. Now, laminotomy, close cousin of the laminectomy in CPT, and a very close, often overlapping relative in surgical reality. So this is incomplete removal of the lamina. It's usually unilateral, but it sure enough can be bilateral. Don't be surprised, you'll see it some of the time. And it's coded per interspace, as you'll see, for example, there L23, almost universally documented as such. It's the question of whether the word laminotomy is used or not. We'll get to that. So you may see in the body of an operative report such as cephalad, that's the upper part of L4, and the caudad, that's the lower part of L3. So removal of parts of 2 adjacent lamina, which forms a window of decompression access for what's underneath. So that's usually where the action is. There's a disc herniation, there's a foramen to be opened up, there's a facet joint that needs to be carved out through that laminotomy. So the laminotomy itself is really just making a window to the problem. Now, discectomy and or facetectomy or foraminotomy is expected and included in the code too. So it's as if the approach of laminotomy governs the terminology for the code itself. The laminotomy is really just like a laparoscopic or open approach. It's what happens inside, but that becomes incorporated in the code. This is where it gets really fun, is the differentiation between a laminectomy and laminotomy and the way that it's described. So we'll see some examples here of obviously laminotomy and obviously laminectomy. Those are easy. Unilateral laminectomy still counts. Incomplete or subtotal laminectomy for spinal canal decompression, when removal of the bone can be ascertained to be the decompressive maneuver, still pretty well within the laminectomy family. On the flip side of that spectrum, laminotomy, hemilaminotomy, and hemilaminectomy are technically all laminotomies, even the hemilaminectomy. That's how it is in the CPT book. It's to whether the surgeon is describing it in a way that you can confidently choose that or not. You really need to look into the body of the report to see that the lamina was substantially removed and that was the decompressive maneuver to call it a laminectomy. Otherwise, I err on the side of being conservative and say it's a laminotomy. Here's a descriptor of the laminotomy code, 63020 cervical, 63030 lumbar is one of the few CPT codes I know by heart, and 63035 for each additional level. Now, a bilateral laminotomy is coded with 2 of these. It's coded with a 50 modifier. And by that same logic, if a unilateral is done, which is usually the case, a left or right modifier is appropriate to be appended. Probably won't cause too much trouble with billing, but it's the right thing to do, so I encourage it. An additional level is a different interspace, not a separate site for the laminotomy. So laminotomy modifiers, you'll have one code per interspace or level, bilateral 50, right or left accordingly, and then each additional level has the separate code. So the second level is second code, and then I have to throw this little tidbit in there. If the laminotomy is done in the same operative session with a laminectomy, a true laminectomy at a different level, well, the laminectomy code presumes the laminotomy is part and parcel of it. So distinguish that as a distinct procedure. The laminotomy done at a separate anatomical site as the laminectomy. Modifier 59 is the way to go, or you can use one of your fancy X modifiers if your payer and facility allow it. So there's this little sort of creature hiding under the rock that I have to pull back in full disclosure and let you know that the CPT assistant and coding clinics do exist, because they will come up, and different facilities choose to handle these the existence of these guidelines differently. CPT assistant from 2012 states that the choice of the laminectomy code 63045 or 7 can be based on the diagnosis of spinal stenosis. Based on the diagnosis of spinal stenosis is listed in the parenthetical note, which is sure convenient for us if it's documented as such, but it does go a bit against the logic of the rest of CPT, which is the first thing you learn is the surgeon needs to have done and documented each of the elements described in the procedural descriptor, that they be there. But nonetheless, this exists. Use it wisely. I can't tell you each and every case of when it's appropriate to code a laminectomy based on that, but you have a CPT assistant to fall back on if you can otherwise substantiate your code choice. Conversely, coding clinic for HCPCS, and it also may depend on whether you're a profi or facility CPT coder as to which of these you trust more, so to speak, says what I would have thought such a resource would say is the code assignment is never based on the diagnosis listed as the reason, that the narrative descriptor of the procedure needs to essentially match what's in CPT. My heart goes more with that one. These conflict pretty much exactly, so I wish I could interpret that for you in a slam dunk. The best I can do is to let you know that they both exist. Now let's move on to another very common type of decompression, and that's the discectomy, so removal of part or all of the disc. Oftentimes it can be as little as just the herniated part, and a few more bites back into the nucleus pulposus to help prevent it from recurring. But it can be removal of the entire disc, but that's usually done with a fusion. The discectomy is done to perform a decompression of the spinal cord and or the nerve roots, usually of a herniated disc. And again, for fusion, I have to have a chuckle with this diagram wherein they just pop the disc right out, like, you know, just scraping out the stuff in an Oreo. You just do that and walk away. I wish it was like that in real life. Far from it. It's really a bloody mess of picking out the disc material piece by piece with usually rongeurs and curettes and other instruments. So on that note, I just wanted to get you to have a look at some of the instruments that are used in orthopedic surgery, including spine surgery too. We have the ever-present Kerrison rongeurs or Kerrison punches right here, and it has a little cookie cutter effect at the tip. So when the handles are actuated, this chomps up and down and it pulls out little bits of disc or bone material, the cartilaginous end plates. It's a pretty versatile tool. Here's a single action rongeur. It's more of a general purpose orthopedic instrument, which has tips like a parrot's beak. Rongeur in French means gnawer, or one who gnaws, like a rat. It's a nickname for a rat, actually, rongeur. So this is just for chomping out bits of firm or a rigid tissue. These are high-speed drills, or burrs, that you see here, and they're just like Dremel tips, but much more expensive and high quality, and these are run off of pneumatic instruments you see here, which it looks a lot like a very fancy and expensive Dremel tool. So discectomy in CPT, when done posteriorly, which it often is for herniation, as posterior herniations are the ones that cause problems. If done through a laminectomy or laminotomy, it's effectively included in the code 63030 or 63047 for a lumbar. The cervical discs are hardly ever approach posteriorly, so a posterior discectomy are almost guaranteed to be looking at a lumbar. Now there are variations of this through not through the lamina, but through the foramen itself. So we'll come to that. The lateral extraforaminal, or also called far lateral discectomy or transpedicular approach. Hopefully, if that diagram's stuck in your head a little bit, you'll remember the neural foramen where the nerve root exits is in effect the window into the spinal canal where the disc herniation is likely to be. So the hallmark of this is that there's no lamina work done at all, at least at that level, wherein the work is done through the neural foramen here. So the lamina is up here. We just made incisions and inserted instruments through the patient's off to the side of the back instead of the midline. Here are your codes for the transforaminal discectomy, 62055 and 56, and for additional levels. So this is fortunately usually pretty easy to recognize and pretty straightforward to code. And then a discectomy for anterior approach. So this is more commonly in the cervical or thoracic, where the actual pathway to the disc is more direct and avoids the spinal cord going anteriorly. Cervical, but more common. Thoracic is a little bit weird. Now, discectomy done from an anterior approach is almost always done with a fusion. So it's rarely coded separately, and it depends on the circumstances. But in any case, these codes do exist for the isolated anterior discectomy when that's all that's done. 63075 and 76 for cervical, 77 and 78 for thoracic. So that's pretty straightforward, but I urge you, if you ever find yourself in this neighborhood of codes, be careful. You've read that note very carefully to see that there's not something else like a fusion done along with it that would dictate a different set of choices of codes. So speaking of spinal fusion, let's move on to that. And spinal fusions are done for a number of reasons. In the purest sense, if you take a joint which is arthritic and painful, from a wrist, ankle, knee, this most foolproof way to alleviate the pain is to effectively eliminate the joint by fusing it together so it ceases to be able to articulate. And that is one instance for spinal fusion. A less common reason for spinal fusion is correct and angular deformity, scoliosis, kyphosis, lordosis, or a variety of other conditions in which the spine needs to be cut, reshaped, and then fused into place. But probably the most common reason to perform a spinal fusion is to fixate a decompression of the spine, of the spinal cord, of the nerve roots, when done at the same time. So decompress the neural structures and then fix that in place. So there's a certain methodology I like to recommend when you approach coding a spinal fusion, and that's kind of like building a banana split from the bottom up. So first you start with the region, cervical, thoracic, or lumbar, and that will guide you to that part of CPT. Then carefully understand which or both of the columns are being fused. And these are distinctly different procedures, but different surgeons are good or bad about differentiating them well within the body of the note versus sort of glomming them together sometimes. So it causes us to have to work a little bit better. But understanding the anterior and posterior columns being fused is crucial. Then come to understand the approach, whether it's an anterior approach, posterior lateral. Understand where the instruments and the surgeon's eyes are coming at the problem too. These can be sometimes combined. There are also posterior approaches to both an anterior and posterior column fusion. So be sure to differentiate the concept of the anterior posterior column and the anterior posterior approach. And then so we've put the banana at the base, the ice cream in the middle, and then the add-ons, the cherries, sprinkles, and all that kind of stuff that you put on top. These are the add-on codes that often don't have a work RVU associated with them, but they're important to report correctly. And these are the likes of bone grafts, interbody devices, instrumentation, plates and screws, and so forth. So let's dive into that a little bit more. So for the region, that part's easy. I'm sure you've got that down. Now we'll look at the columns being fused. So the anterior column fusion is the disc interspace. That's the joint that's being fused. Remember, a spinal fusion is fusion of a joint in every case. So anterior column is the disc interspace, is the joint being fused. And then the posterior column fusion is fusion of the facet joints. Now, the facet joint fusion may be done by excising or obliterating the facet joints, or even leaving them right in place. But the posterior elements being fused are meant to isolate and disarticulate or unarticulate the facet joints in the posterior column. Now, anterior and posterior fusions are often done together, so that has the effect of fusing the anterior and the posterior column, all three joints at that level. So the posterior fusion is of the facet joints and the posterior elements around the facet joints, usually done with a decompression procedure itself, and quite often with an anterior fusion as well. Imagine fusing all three joints of that tripod effect has the strongest stabilizing effect at that interspace, whereas fusing just the posterior elements and leaving the disc to articulate can cause a pseudoarthrosis. The posterior fusion may release. Conversely, just an anterior fusion, anterior column fusion in the lumbar spine, which is much higher stress than the cervical spine, the facet joints still potentially articulate too. So the most foolproof way is to fuse all three. The approach to a posterior fusion is always posterior. So they can scratch that off your list. It's easy to remember. Why would you go through the vertebral body, the disc space, past the spinal cord and the nerve roots just to get to the posterior column? So it's never done. The add-ons for posterior approaches are the bone grafts, meant to encourage the bones to fuse together, and the instrumentation, which is only there to hold it as long as it takes to fuse. Doesn't actually add a whole lot of strength to the construct, but it keeps it there just like a cast on a fracture so it can heal up. Posterior fusions by regions, fairly straightforward: cervical, thoracic, and lumbar, each additional level. Okay, and since it is at an interspace, we don't have to worry about that whole laminectomy, trying to figure out what's a segment and what's a not. It's always an interspace. And then the posterior fusion add-ons, we have the likes of non-segmental instrumentation, which we see here on the left. Non-segmental includes only 2 points of attachment. They can be two adjacent vertebrae, or they can be remote from one another, but in reality it's usually the two adjacent. Segmental, as we see here on the right, is 3 or more points of attachment too. So effectively, look for the number of screws used is a pretty foolproof way to see. If it's 4, it's non-segmental, and if it's 6 or more, virtually always, like, as best I can think of, an even number, you're probably dealing with a segmental. And there are slightly different codes for that. 2 points of attachment, 3+ points of attachment. And here's an example of what you might see, like in this diagram, or this photo here. Pedicle screws placed through the pedicles, remember those, at L2, L3, and L4. 2, 3, and 4. Here's their decompressed spinal cord hanging out right in the middle, and the idea is just to fuse the facet joints and the lateral structures here and here. Here's bone graft used as a sort of a lattice work for the bone, the patient's own native bone, to grow in and through and around to fuse the whole joint together. An autograft from the same incision, remember the SPINOUS process that I told you was removed during laminectomy? Well, this is a good use of reusing that patient's own bone, acquired right then and there, through the same incision for spine surgery, 20936, and or allograft morcellized. And you can use these both in CPT, and they are actually in practice often used alike. The autograft is often not quite as much volume as is needed, so they'll throw a little cadaver bone in there too, which works as well. In either case, after several years, those are both turned over into the patient's own bone, and it becomes purely native bone. The anterior fusion is fusion of the vertebral bodies across the intervertebral space. And so what starts off in there, of course, is the disc needs to be fully or partly removed. Now, whether to code that or not depends on whether that disc removal is simply for preparation of the space, or whether it is itself a decompressive maneuver. So if the disc is herniated or otherwise causing problems, you've already got cause to remove part or all of the disc, and then the fusion almost then becomes happenstance afterwards too. So if it's included, the discectomy is included if it's for prep. It's coded separately if it's for decompression itself, and demand pretty exacting documentation as to the indication for the discectomy. And then something needs to fill that space. You can't just let the vertebral bodies slam down on one another. That would cause the compression problem number 4 that I mentioned early in the presentation. So what we put in there is called an interbody fusion device. One version of this is a peak cage. It's polyether ether ketone. It's a very inert, very rigid and strong and bioneutral plastic. It's just a plastic. It's just incredibly durable, and the body doesn't react to it at all. Also can be used allograft, structural allografts, which are milled, that is carved out of cadaver bones, like a cross-section of a humerus that's milled into place. I'll show you a picture in a minute. And it can also be autographed. I've personally yet to see one of these done, but it's not impossible to think a certain patient might require, say, excision of a rib or a fibula that is then fashioned into an interbody space. But in any case, all three of these examples are meant to hold the disc space open while it is filled in and obliterated with the patient's own bone. So the main caveat about anterior fusions, interbody fusions, is that it's interbody. So any fusion that you see that's got IF, interbody fusion. Interbody fusion. Those are all anterior column fusions. That's critical. In this case, these are lumbar interbody fusions, and there are cervical fusions as well. And then the first letter in these is typically the approach, or some proprietary set of apparatus and the assigned approach. An XLIF and a DLIF, those are proprietary names for those vendors for the approaches they develop for these anterior antibody fusions. But what you'll see, here's a patient laying laterally, so their back is here and their belly is up here. And there's the approach of the instruments to the vertebral body, which governs whether it's an anterior or a posterior approach. So these are divided for CPT purposes into just two families, a posterior approach and an anterior approach. Now, the anterior approach through the belly is obviously anterior, and the posterior approach through the patient's midline of their back, that's pretty intuitive too. That's easy. Transforaminal, still through the patient's back. That's pretty intuitively posterior. But what about the XLIF or DLIF, which is actually through the kind of the side of the patient, if anything, maybe even a little bit anterior, but it's directly to the anterior vertebral bodies. So that's an anterior approach, believe it or not. So by definition, think about it like this. If the approach to the anterior column is through any of the elements of the posterior column, including the foramen, including the lamina, that's a posterior approach. If it's anything else, in other words, a direct approach to the anterior column, it's an anterior approach. Now the ACDF, or anterior cervical fusion, with a discectomy preceding the fusion. Now, this is the case where the indication for the discectomy is critical and the degree of removal is important in the consideration of the coding. So we've got the plain version of the ACDF in which the disc is removed just as preparation for the interbody space to receive the interbody device. And then there's the extra, or what I might have called earlier, deluxe, is with a decompression. So that's where the discectomy and osteophytes and usually the PLL are removed and in a decompressive maneuver themselves, separately from the fusion. Okay, let's look at some anterior fusions in CPT. So we'll start with the cervical. Didn't include those in the diagram, but these are quite commonly done. ACDF, anterior cervical discectomy and fusion. There are two varieties of these, and depending on whether the discectomy itself is as a decompressive maneuver, as the disc is herniated or bulged, or as access to the foramina to decompress there, or whether the discs are just partly or completely removed to allow insertion of the interbody device. More commonly the prior, actually this one, the extra, so forth with the decompression. Here are your CPT codes for the first and subsequent levels. Now the lumbar anterior interbody fusions, remember the anterior lumbar interbody fusion, obviously anterior. Extreme lateral and the direct lateral, also anterior approach. So here is your first and additional levels. And there's very close codes, 22558, 22585 too. That's not to be confused. And then you got your posterior approach for the anterior lumbar interbody fusion. So posterior is obvious, the transforaminal, remember it goes through the posterior elements to the anterior column. That's still a posterior approach. First level, additional levels. And don't forget all your add-ons for the instrumentation and the grafts as discussed. So to back up just a little bit about what the XLIF and DLIF might look like, here's from the vendor's website. You can see this tubular retractor being placed in through the patient's flank, through the psoas muscle directly to the intervertebral space right here, but avoids the peritoneal cavity here and avoids all the posterior elements here. Now, these are just barely about to become truly endoscopic, but as it stands right now, the surgeon's eye and instruments go right through this. However narrow it is, it's a retractor. It's still an open approach. Forgive me while I digress a little bit in PCS concept, but it's still open approach. Now, it wouldn't surprise me if CPT also begins to delineate an endoscopic and an open approach to some of these procedures too. Doesn't know the technology, it's just right on the cusp of doing that. Here's this different proprietary set of instrumentations in this sort of gantry frame that holds the instruments and the retractors out of place. It's more clearly open, but still avoids the peritoneal cavity and avoids the posterior structures and goes directly at the anterior column, hence anterior fusion. So the anterior fusion add-ons, I showed you some morselized bone graft. Here's some interbody devices. We have from the metal titanium type, which are meant to be, these are put in, through an X-lift or D-lift approach through those tubular retractors so that you can see that they're kind of skinny and corkscrew shaped and meant to be inserted in pairs, versus the peak cages you see here, which are constructed into a sort of a wedge shape with ridges along the top, some kinds of locking mechanisms. There's all kinds of versions of these too that provide an additional lordosis or kyphosis, that is the angle between the adjacent vertebral bodies which are being fused. There's some old school, truly cage-looking cages stuffed with allograft and autograft here. Here's some synthetic ceramic types, and there looks like another peak cage. But in any case, the same principle applies. It's put right in between the vertebra, and it's meant to encourage bony growth around and oftentimes through like here, the device itself. Now there's the interbody structural allograft too. You see on this bottom row here, these are made out of cadaver bones that have been carved by a machine to a certain particular shape, and that bone is resorbed gradually by the patient's body and then replaced with its own native bone, which is kind of an attractive idea if you think about it. Here's some morselized allograft and autograft as well, which is commonly put in and around the intervertebral device or allograft, structural allograft, to act as a lattice work for the bone to grow through. And then anterior instrumentation for anterior column fusion. So you can't really just stuff in that interbody device or graft and walk away. It needs to be held in place. It's effectively a fracture at that point. It needs to be held. So here you see some anterior instrumentations, plates and screws, plate and screws, which is coded separately. And here's an interesting case of an integral anterior plate device in which the spacer itself behind here has a plate affixed to it through which screws are placed not through the anterior surface of the vertebral bodies, but up into the end plate and down into the end plate of this vertebra. So this sits flush against the anterior surface of the cervical neck where the esophagus descends anterior to the neck. So patients with a zero profile is one of the proprietary names for one of these devices. Their esophagus doesn't have to go down and around any screws or plates right there. It's all kind of stuffed nicely up inside the interspace. So looking at the CPT coding for these interbody devices, they've recently been changed for 2018 to incorporate that concept of the integral plate directly in CPT without having to refer to CPT assistant. So effectively, with or without integral plates, if it's manufactured and installed with that plate in place, as in these three examples you see in the bottom right, it is considered part of the same code. It can have 2, 3, or 4 screws and so forth, as long as the plate is affixed to the interbody device. It's with an integral instrumentation or without. Now, where it does differentiate as to whether it's for a fusion, 22853, with a corpectomy, which is still for fusion, but it's a more aggressive removal of an entire vertebral body, or most of one, which I'll show you in a moment. Or it's without interbody fusion. I don't know what that is, why you would take out part of a vertebra and stuff one of these in if you didn't intend for it to fuse. So be looking out for the first two, 22853 and 4 predominantly. And then add-ons for the anterior fusion. You have again your the CPTs here. We've discussed all these concepts, but just so we can have a look at the codes. Notice I've preceded each of these with a plus sign for structural or morselized allograft. Autograft for the same incision for spine surgery only. Anterior instrumentation, plates and so forth, segmental or non. Anterior plates, depending on how many vertebral bodies are affected, 2 or 3, 4 to 7, or beyond 7. And then the posterior segmental and non-segmental add-on codes. So remember again, the posterior segmental is 3 or more points of attachment, or three or more levels of attachment. So 6 or more screws. Think of it that way. Now, here's a couple of challenges. Combined fusion in CPT. We'd never do this in PCS, but in CPT we can, in the instance of a lumbar. Because it's, as I mentioned, to acquire that tripod fixation arrangement of the anterior column and the posterior facet joints, commonly both are fused at the same time. Indeed, there's a CPT combination code for those, 22633. And it's pretty easily described in the CPT descriptor: combined anterior posterior fusion, posterior approach. So they'll go through, commonly make a laminectomy, push the spinal cord out of the way, achieve access to the interbody space, put the interbody device and graft in there, and then pull back, acquire some allograft or autograft through the course of the decompression, and then apply that down the sides of the facet joints and the lateral transverse processes and other lateral structures to fuse the posterior column. There's your code for that. In the cervical spine, there's not, because you really can't do this through one approach. You can't get to the posterior column to fuse it through the anterior, and an anterior fusion makes no sense to approach posteriorly because the anatomy is so small, packed together in such a way, and very close to the spinal cord that it's just not plausible in 2018 to do an anterior cervical fusion through the back of the neck. So you have two approaches. You almost kind of need to have the two CPTs, and there you'll see them. But in either case, be sure to add on the instrumentations, the grafts, and the inevitable interbody device or structural allograft. Let's talk a little bit about what to do when a laminectomy and a fusion are done at the same site at the same time, say a lumbar, a laminectomy, and a discectomy and a fusion. So let's revisit the code descriptors for these, and also failed to notice or mention that the fusion codes are all found in the musculoskeletal part, because they are truly to immobilize and fuse bony structures together, joints, whereas the decompression codes are in the 60,000, that's the neurologic surgery sections too. It's just kind of interesting, these closely allied procedures are found in totally different parts of CPT. In any case, so we've got your arthrodesis code, posterior interbody technique, including laminectomy, discectomy, and so forth, to prepare the interspace. So the discectomy there and the laminectomy is other than for decompression. So that's a single interspace. And then we'll look at the laminectomy code, 63047. That's the part that's for the decompression. So on the surface, it would seem like you have two separate intentions of this. We're decompressing it with the laminectomy and you're fusing it otherwise. And that laminectomy, when done for decompression, presumably was for more than just access to provide the arthrodesis device in the interbody space. So it looks okay on the surface, right? So as we might see in this example of documentation, complete L4, I'm making this really exaggerated so you can help kind of understand the concept. Complete L4 laminectomy with bilateral facetectomy and foraminotomy at L4 for central and lateral canal stenosis and foraminal stenosis, right? This is a really aggressive decompression of everything at that level. So that seems like a slam dunk. And then followed by a posterior lumbar interbody fusion at L4-5 at that same level too. So what we would come up with is 22630 right here and 63047. Now, here's where it gets interesting. There is an NCCI edit against that combination of codes, but with a 59 allowed. Now let's remind ourselves of what a 59 distinct procedure modifier means. It's a distinct procedure at a different location. There's anterior column fusion, posterior column decompression. Heck, you're looking at two different body systems, musculoskeletal and nervous. So in my heart, I feel like this really should be allowed. And in CPT, indeed by the NCCI edit, with the modifier allowed, it is technically allowed with that modifier, but CMS says no. The policy manual says these will not be paid together by CMS. So use your discretion if you code by the payer. You have to avail yourself of all of the contractual fine print as to whether you can or cannot build these together, or you could choose to code them and allow them to be edited off the claim. Or if, like most facilities, you go by CMS rules, you're kind of compelled to not code the laminectomy, even if it was for aggressive decompression. When it's done with the fusion, it just becomes a freebie at that point. Okay, let's look at some of the rare instances of a laminectomy when done as an approach for something else, not as a decompression, but as truly an approach. And these have unique codes. Here's some examples. 63282, laminectomy with excision of intradural extramedullary neoplasm, lumbar, like a subdural metastasis, like a cancer. inside the dura, but outside the spinal cord. That's what the intradural, inside the dura. Extramedullary means outside the substance of the central nervous system, in this instance, the spinal cord. Then we've got laminectomy of excision of extradural intraspinal lesion, so outside the dura, but inside the spinal canal. That might be like a facet cyst or some other benign lesion outside the dura. Now, these are not per segment, so this is the one key point. If a patient has a very large metastasis, say they may need to remove 3 or 4 lamina to get the whole thing out. This is just treated as one laminectomy. It's not coded per level or per segment. Okay. Now, if it's a different level for a different problem, it's not impossible to imagine a patient having a lesion excised at one level and a decompression at a totally different level. Then you may be justified. I have not personally run across that scenario, but you can be vigilant of that. In any case, demand excellent documentation to really differentiate those 2 separate indications at 2 separate sites before you consider using these 2 codes together. Here's an example of an intraspinous lesion excision by laminectomy too. So here is the spinal cord itself, the dura, and the spinal canal extradural space. So you can imagine the lesion here, a lesion here, or intramedullary is actually, again, in the substance of the spinal cord. So those are your 3 levels. 1, 2, 3. And it's, of course, it is done by region of the spine and whether neoplasm or non-neoplastic. A corpectomy is an instance, it's like a very aggressive anterior cervical fusion. And yes, there are 2 different CPT codes for placement of this device, depending on the intention. But by and large, consider corpectomy as just sort of an extension of a normal interbody fusion. It just occurs through removal of all or most of a vertebral body. So it's going to be done as an approach through the anterior column to the spinal canal. And but you still code it as a corpectomy if that vertebral body is removed. It could be partial or complete, and it kind of depends on the percentages removed, which I'll show you in just a moment. Now, this is not just preparation for a normal fusion. As you can imagine, this is a quite aggressive removal of 1 or more vertebral bodies, in this case 2, and then bridged in place with what's in effect just a very long interbody fusion device. Now, it's 1 fusion per device for the fusion part, but the corpectomy, we code as many times as vertebral bodies are removed. But this we can consider 1 long contiguous interspace that's now created. Therefore, it's 1 fusion per device. So to code a corpectomy, we must know the indication for the procedure and the approach and the location. So decompression corpectomy, 63081 for cervical segment. If done for extradural lesions, so that would be coming in through the front of the patient's body, removing a vertebral body, taking out an extradural, or in this case, intradural lesion in the cervical or lumbar. These are just examples, approaches. And in thoracic, there is actually the addition of the lateral extracavitary, which is through it's in effect like an XLIF to the lumbar body. So it's through the ribs and the side of the spine to get to the front, to carve out the vertebral body there. And then there's a transthoracic, which is right through the chest. And then thoracolumbar is entering through the lumbar region, then going up into the thorax. This pesky ribs just get in the way of the vertebral bodies that these clever approaches have to be used to figure out how to get to the anterior column of the thoracic spine. Now, the requirement in CPT assistant for the degree of vertebral body that must be removed to count as a corpectomy is 50% in the cervical region, and thoracolumbar is 33% to code as a corpectomy. I like to educate surgeons to be careful about designating what percent of it they remove if it's anything less than the whole thing. And again, the interbody devices are per defect, not per vertebral body removed. So corpectomy is per vertebral body, but the interbody device is just 1 device, whether it's interspace, whether it's through 1 corpectomy, or 2, or 3, no matter how long that thing is, it's 1 device, 1 space. Now, what do we do with a facet cyst excision? Here's one more other little challenge to think about. Now, it is an extradural, extramedullary interspinous lesion in effect, yes. Are these encountered incidentally A lot of the time, yes. Are they sometimes removed as the principal focus of the surgery through a laminectomy? Yes, sometimes, and that's all that's done. So some of those circumstances factor into the way I recommend that you consider coating the facet cyst excision. Now, if it's done as part of a laminectomy with a facetectomy and discectomy, in other words, other decompressive means, wherein the surgeon goes and makes a laminotomy, takes out some disc, carves out the foramen, removes some of the facet, and the cyst is there at the facet, also compressing the nerve roots and or the spinal cord. I like to consider that as just part of the laminotomy, as it includes the facetectomy and the discectomy there. If it's part of a decompressive laminectomy, I also treat it the same way, because that 63047 is really meant to encompass the concept of decompressing everything at that level. It's just with a complete removal of a lamina. And now, if it's done as through a laminectomy as a discrete lesion, like that's literally the facet cyst is acting as sort of a tumor, a space-occupying mass that's pushing on the spinal cord. 63267, removal of extradural intraspinous lesion, non-malignant, that might actually be the right code if there's no other decompression going on. So I think you can honestly feel confident about using that code in that case. But be cautious of using additional laminectomy codes with that. In that case, the laminectomy is truly just the approach. It ceases to become a therapeutic intervention because there's no other decompression going on. So to back up to say, if it's part of a bigger decompression, use your ordinary laminectomy, laminotomy codes. If it's just a unique focused removal of a lesion, consider your lesion excision codes. This concludes our webinar for today on spine surgery coding. I hope that was fun for you. Below you will find a link to the post-test, which you have 2 opportunities to take and achieve a score of 70% or higher. And having done so, you can earn your CEU 1 hour through AHIMA or AAPC, and the certificate will be printable there for you. Again, this has been Ed O'Byrne with Healthcare Resource Group, and we'll see you the next time. Be well.